Hello, everyone. My name is Laz Boris, and I'm the president of the Thyroid Foundation of Canada. I'd like to welcome you to our educational webinar. Our guest speaker today is Dr. Antonio Bianco, who will be presenting the medical version of his last year's presentation on Rethinking Hypothyroidism, why treatment must change, and what patients can do. Dr. Bianco is a professor of medicine and a member of the Committee on Molecular Metabolism and Nutrition at the University of Chicago, where he runs a laboratory funded by the National Institute of Health to study thyroid hormones. He's also a former president of the American Thyroid Association. A question and answer session will follow the presentation. Catherine Keene, our administrator, will be acting as producer for this webinar and managing the technical aspects of Zoom. If you have any technical issues during the webinar, please reach out to Catherine via the chat feature. Some of our board members will also be assisting. Michelle Sveistrup, Director of Education and Publications, will be looking after the Q&A section. Laurie Martin, Director of Volunteer Recruitment and Development, will assist us in the chat room. This event will be recorded and made available on our website later this week. A little bit about housekeeping before we begin. Today we're using the webinar functionality of Zoom. This means that you can see and hear the presenter and support team, but your audio and camera are not active and we're not using the raised hand feature. You're able to communicate with the other attendees using the chat feature at the bottom of the screen, so please feel free to join in. If you do not wish to see the chat previews displayed at the bottom of the screen during the presentation, please click on the chat button arrow and deselect the Show Chat Previews option. Please use only the Q&A feature located at the bottom of your screen for your questions to the presenter. We will not respond to questions entered via the chat feature or from emails. Please note that our webinars are presented in English. If you wish to have subtitles in French or any other language, please select the CC closed caption option at the bottom of your screen and choose your preferred speaking language. At this point, we're ready to begin with Dr. Bianco's presentation.
Thank you, Laz, for the kind invitation. It's a pleasure to be here and speaking about hypothyroidism. I'm going to first share my screen. And my slides are here. So is that okay?
Looks good.
Okay. So these are my disclosures. Why are we talking about or revisiting treatment for hypothyroidism? We all know that the standard of care for treating patients with hypothyroidism is with levothyroxine. However, as a group, patients with hypothyroidism on levothyroxine that have normal TSH values, that's how we know the dose of levothyroxine is correct, exhibit reduced quality of life and impaired cognitive functions, such as learning, memory, attention, cognitive speed, etc. This has been first documented in the UK, in Wales, and subsequently reproduced in the Netherlands, and then further reproduced in other countries in Europe and the United States. So there's no question that patients on levothyroxine as a group, most do well, but if you start investigating with tests and questionnaires, you will see that there are issues under the surface. Now, this is an example. I like this publication, was just published maybe 2 or 3 weeks ago. And you can see that this is a group of almost 6,500 patients on levothyroxine compared to more than 100,000 controls. And you see that there are lots of parameters that were assessed through different questionnaires. And you can see here, if there's no difference between levothyroxine and control, all these dots will be on top of the line. But because they're shifted to the right, you can see that there's a difference, meaning patients on levothyroxine are 1.8-fold more likely to experience, for example, higher health dissatisfaction. These are the odds ratio. And you can see that all of these parameters are affected highly significantly in the group of patients on levothyroxine. Now, in addition to issues with quality of life and cognitive activity, we also have metabolic features for patients on levothyroxine. We know that patients on levothyroxine have slower basal metabolic rate. When I saw this, I was actually surprised because I did not expect, I thought that by normalizing serum TSH levels, we would also normalize energy expenditure. In fact, that's not the case. They have subnormal. And as a result, these patients, again, as a group, weigh 10 pounds more in average than their matched control. We did the study using enhanced data here in the US, and we created a matched control population that was matched by multiple parameters, and yet the patients on levothyroxine weighed about 10 pounds more. They also exhibit higher cholesterol levels. So what does that mean? We know that patients with hypothyroidism have high levels of cholesterol, but I always assume that when we treat these patients with levothyroxine, you see a lowering of cholesterol levels, and I would assume that they will return to control levels. But in fact, they don't. They remain slightly higher, and most importantly, they are twice as likely to be taking therapy with statin. The number one co-prescription medication for levothyroxine is statin, meaning that we can't normalize cholesterol once we start with levothyroxine. Most likely, the reflex reaction of the physician is to place these patients on statin. Now, this was one piece of evidence that I wanted to show to you because this is all published in peer-reviewed journals and there's not a lot of questions about it. Now, the second piece of evidence that I want to share is that treatment with levothyroxine is not physiological. I know this is sort of a bombastic statement, but I'm going to explain what I mean. I mean, it fails to restore normal thyroid hormone homeostasis. What do I mean by that? Look, the thyroid produces these two hormones, T4 and T3, and we know T3 is the active hormone. When we treat someone with levothyroxine and we are restoring all those symptoms, we are restoring, eliminating the system, restoring the normal functioning of the body, it's not T4 that's doing that. T3 is T3 is the one that does that. So this axis, this system, the thyroid system that it includes the hypothalamus, the pituitary gland, and the thyroid itself, it's geared, it's wired to preserve serum T3 levels within the normal range. So T3 is really important for this system because T3 is the biologically active thyroid hormone. And here's how we know where T3 is coming from. A little bit from the thyroid. Most T3, however, is produced outside of the thyroid gland through these enzymes that are known as deiodinases. So when we treat our patients with levothyroxine, now this whole system is no longer functional because the thyroid is no longer functional, either because it was destroyed by Hashimoto's disease or by radioactive iodine or by surgical thyroidectomy. It really doesn't matter. The system was disconnected. And we are now relying on the deiodinases to defend serum T3 in the circulation, the hormone that actually restores thyroid hormone thyroid hormone signaling. So we trust that these deiodinases will take the T4 from the tablet and make sufficient amounts of T3. The question is that actually true? So there has been, since the 1970s, dozens of studies that have addressed that question. And overwhelmingly, the studies show that patients on levothyroxine have subnormal levels of T3. Either there's a relative decrease of T3 or an absolute T3 decrease of T3. Now, these are cross-sectional studies. I'm going to show you data from a large longitudinal study that we just published. These are, in Brazil, there's this cohort of individuals that are followed for a number of years, 15,000 individuals, and they are being followed for, and here I'm going to show you data for 8 years. So they were studied 3 times during these 8 years. And so we have free T4 levels here, and the blue line just shows how free T4 levels fluctuate or not. It doesn't actually fluctuate over these 4 years in a control population. Now, we also have individuals, about 200 individuals, in which we had data from when they had a healthy thyroid, and then during the next follow-up, they had been diagnosed with hypothyroidism and treated with levothyroxine. So we have for the same patient, the control, the baseline levels with a healthy thyroid, and 4 years later, once they were diagnosed with hypothyroidism and treated with levothyroxine. And these are the green and the red lines, before and after, before and after. And you see that once the patients are placed on levothyroxine, their free T4 levels increase by about 20%. The TSH levels decrease by about 10-15%. And despite the elevation in T4 and the reduction in TSH, the T3 levels are decreased, meaning they had a certain level of T3 when they had a healthy thyroid, and now on levothyroxine, they have a slightly lower T3 levels. Now, you're seeing, I'm not trying to convince you that 5% or 6% is greatly significant, although we don't have data to assess that. But we sort of looked at individual patients, all those 200 patients, and we saw that indeed 60% of the patients, this is before and this is after they were placed on levothyroxine. 60% of the patients do maintain normal T3 levels. What do I call normal? They are either on top zero change or plus minus 10%. So I figure that a change in 10% is not that significant. Some patients actually have a slightly increased T3 levels, but the critical finding is that 40% of the patients have a substantially reduced T3 levels, 20, 30, almost 40% reduction, meaning these patients, before they were treated with levothyroxine, they have substantially higher levels of T3 in the circulation. Now, let's note now a second group of patients within the same cohort. Now we have patients that have been treated with levothyroxine for 8 years. So we have these 250 patients, and we have 1,000 matched controls. We matched for everything. Look, we have here free T4 levels, free T3 levels, mean plus minus 2 standard deviations. Look what happens when we looked at the population of levothyroxine-treated patients. The T4 levels just go up. They're all concentrated in the plus minus 2 standard deviation. You see that all this area here in the bottom of the normal range, now it's empty, almost empty. And there are lots of patients with T4 levels that are above the normal range. Now, the opposite is seen in the T3 levels. See, all of the patients now are at the bottom of the normal range. The upper half is empty, and many patients are below the normal range. So this is what we are doing with our patients once we put them on levothyroxine. We create a relative excess of T4 and a relative and many times absolute deficiency of T3. This is another way of showing the same data. See, the red bell curve is the control population, and the green bell curve is the population of patients on levothyroxine. See, there's a shift to the right, and a number of patients are above the normal range. Look, in the case of T3, there's a shift to the left. Everybody has a lower T3 level, and also individuals, a substantial number with T3 levels that are below the normal range, below the normal range. So that hormone that's supposed to restore thyroid hormone signaling and resolve symptoms of hypothyroidism, we're maintaining lower than normal levels in the circulation, even though the TSH is normal. So when we use TSH as a surrogate for thyroid hormone signaling, for adjusting the dose of T4, we are creating this population of individuals that have an absolute deficiency of T3. So this is what we think is happening. We treat patients on levothyroxine. We normalize TSH with a relative excess of T4 and a relative deficiency of T3. Now, how do you fix this? The only way we have today to fix this is to combine treatment of patients with hypothyroidism of levothyroxine plus T3 plus liothyronine. We want to lower the levels of T4, and we want to increase slightly the levels of T3. So we use combination therapy. And we just recently completed a study here in the US, and I was surprised to see that there are about 2 million patients taking combination therapy in this country. I didn't expect that. So we think there are 20 million patients with hypothyroidism. 2 million are taking combination therapy. 400,000 approximately are taking synthetic levothyroxine plus liothyronine. About 1.5 million are taking combination therapy in the form of desiccated thyroid extract. So if we want to put patients on levothyroxine plus liothyronine, essentially what we do is we reduce the dose of levothyroxine and add a little bit of T3. For example, if a patient has a normal TSH level with 100 micrograms of levothyroxine, we would reduce it to 87.5 and add 5 micrograms of T3. Different combinations can be used. This is sort of you have to work with the patient and listen how they're feeling, checking the labs, but you have to reduce the dose of levothyroxine to create room for the addition of T3. Otherwise, you're going to suppress the TSH. And I am not supportive of suppressing TSH when starting combination therapy. I know many patients have difference in opinion, but we have to keep in mind, one thing is to give recommendations for the whole group of patients with millions, tens of millions of patients with taking levothyroxine or with hypothyroidism, as opposed to one individual patient. So if you focus on one individual patient, we all know that you can have differences in that patient that they don't necessarily have to follow the guidelines. But when issuing recommendations for the whole group, we really have to focus on the TSH. Now, TSH must remain within the normal range. Patients should be followed up closely. We need to monitor patients for adverse reactions. If the patient has a cardiac condition, we should talk to the cardiologist and see if that's going to be a problem for that patient. But basically, this is what you are doing. These are T3 levels and different ratios of T4 to T3 that we're giving to patients. These are here, a patient is taking 92.5 mics of levothyroxine, 3.25 mics of T3 twice a day. You see that T3 fluctuates because it has rapid kinetics, but still well within the normal range. This is what we want We don't want these spikes of T3 above the normal range. So if you give a little bit more T3, you reduce the dose of T4 further, and then the fluctuation is a little more intense. Here, you're giving 10 micrograms of T3 twice a day, have big spikes, but still within the normal range. So you need to adjust down the dose of levothyroxine to create room to maintain the T3 levels during all the excursion of the T3 levels within the normal range. You don't want to create thyrotoxicosis. You don't want to suppress the TSH. Now, another piece of evidence that's really important, clinical trials. More than 20 clinical trials have been done comparing levothyroxine versus levothyroxine plus liothyronine. There are at least 3 meta-analyses that consider all these trials. And when you look at the effectiveness of both treatments in terms of patients' clinical status, quality of life, psychological distress, you see there's no difference. Both treatments are equally effective. Depressive symptoms, fatigue, both treatments are equally effective. So it's very important to keep in mind that when we compare levothyroxine with combination therapy in these trials, as the whole group of patients, there is no difference. Levothyroxine is not better than combination therapy. Combination therapy is not better than levothyroxine. Now, how about if we consider only the patients that have residual symptoms? Now, we're not talking about the whole group of patients anymore. We're just talking about the patients that have residual symptoms of hypothyroidism. Are they more likely to respond positively to combination therapy? Yeah, we tested that in a randomized clinical trial in which patients were crossed over from levothyroxine to DTE or combination therapy with synthetic T4 and T3 for 16 weeks each one of these arms. TSH was within the normal range. And what we saw is that if the patients on levothyroxine did not have a lot of symptoms, residual symptoms, in other words, if they were okay on levothyroxine, as shown in these 2 graphs, once they were switched to combination therapy, there was no improvement of the condition. Of course, they were okay on levothyroxine. They didn't get any better on combination therapy. Now, the patients that were not okay on levothyroxine, they had a higher level of residual symptoms. Those are the ones that responded positively to the combination therapy. So, is this safe? I'm going to fly over this. I don't have a lot of time, and I'll be happy to address that later. But all the clinical trials combined could not find difference in adverse reaction or adverse events when they compared T4 with T4 plus T3. In Scotland, there was a study that looked at 400 patients for 15, 16 years, and they didn't find differences in cardiovascular outcomes. In Sweden, they looked at 11,000 individuals on liothyronine for about 8 years. Again, no increase in all-cause mortality. So we ourselves looked here in the US in individuals taking levothyroxine or combination therapy in the form of DTE or synthetic levothyroxine plus T3. And we saw that there was, again, no differences in the utilization of healthcare utilization for cardiovascular events or bone health-related events. So safety, again, no difference. So one amazing thing, so we have effectiveness is the same, safety is the same, and one thing that we have not considered for whatever reason, I cannot understand why, all of those randomized, double-blind, placebo-controlled trials, they found something interesting. They actually they asked patients, which drug do you prefer, 1 or 2, A or B? Patients didn't know what they were preferred. They were blinded. And when you do the meta-analysis for trials that lasted less than 12 weeks, or for trials that lasted more than 12 weeks, you see that patients actually prefer 2.8, the odds ratio of preferring combination therapy versus monotherapy, 2.9 greater in favor of combination therapy, 2.1 in the longer trials, and when combined in about 600 patients, patients clearly prefer combination therapy. This is all blinded. They didn't know what they were taking, okay? This is the graph that I find it amazing. I mean, I think we should print this out and distribute, because I just can't believe that we were sitting on this data and not looking at it, not really, discussing this. 50% of the patients prefer combination therapy. 24% have no preference. And a minority, another 24%, prefer levothyroxine when considering all patients taking with hypothyroidism. So why are we not talking about this among ourselves? Why are we not telling our patients, listen, you have 2 treatments here. They're both safe, they're both effective, but most patients do prefer combination therapy. I don't understand. Anyways, this is what we have, these 2 forms of treatment. Luckily, the guidelines of the clinical professional associations have changed, and they have evolved. And now I'll just go to the bottom. NICE, which is a very important group that issues guidelines in the UK, the American Thyroid Association, the European Thyroid Association, British Thyroid Association, Society for Endocrinology in the UK, they all recommend the same thing. Start treatment with levothyroxine. Most patients will do perfectly fine. For those that don't do well, try combination therapy, because many, if not most, will respond positively. So what this is my last slide. What I think the take-home message that I want to tell you is that treatment with combination therapy is safe and effective. Patients actually prefer combination therapy, even when they're blinded in a clinical trial. How do we decide this? The idea is start with levothyroxine, and if that doesn't do, if the patient doesn't fully benefit, we would try combination therapy. Now, once we try combination therapy, we need to adjust the doses, how much T3, how much T4. This is a customized approach. Physicians should monitor T4, T3, TSH, and most importantly, talk to the patient and consider the individual preferences and explain any risks. Although I have to tell you, I didn't see any additional adverse reactions in combination therapy. Not a single trial found that. But I think we should explain and help the patient make a decision, and not immediately say you should feel well on levothyroxine. Let's not consider anything else. No, I think that we have an alternative that can be easily tried for these patients. I'm going to stop here and open the floor for questions. Thank you very much.
Okay, so the first question is that there does not seem to be consistent information regarding the interaction of all forms of estrogen when women are taking replacement dose of levothyroxine, based on studies that are available through JAMA, endocrinology, and the OBGYN journals. What is the most current reliable information? And if there is an interaction, what is the average dose increase of levothyroxine to use estrogen?
Well, I mean, I think the question has to do with the fact that patients taking estrogen replacement therapy or even contraceptive containing estrogen will experience changes in the kinetics of T4, mostly T4, a little bit less on T3. You will see that you need to increase the dose of levothyroxine. How much we increase, it will depend on the dose of the therapy that the patient is placed on. We know that during pregnancy, which is also another situation of increased levels of estrogen, we have to increase the dose of levothyroxine by 20 or 30%. So I would assume it's within this ballpark, but the adjustment needs to be made every time the patient starts or ends or changes the dose of the estrogen replacement therapy, and the adjustment is based on TSH levels. So you will normally see that the TSH will increase because it will speed up the kinetics of T4, but once you increase the dose, you're going to bring the TSH levels back to the normal range.
Perfect. Thank you for your answer. Another question we have is about since the fact that higher normal free T4 levels acting on the integrin alpha V beta 3 receptors promotes cancer mortality. We're wondering if consequently does levothyroxine monotherapy actually lead to higher mortality as well?
Yeah, that's a very good question. Amazingly enough, levothyroxine has been approved by the FDA without, I'm going to repeat, without clinical trials. So we actually have never, the FDA never asked for the manufacturers of levothyroxine safety or demonstration of safety or effectiveness. Therefore, formally, I can tell you, we don't have an answer for that question. However, there are observational studies showing that there's no evidence that the utilization of levothyroxine might be associated with increased mortality if used in the normal doses, in the correct doses, which are the doses that normalize TSH levels. It will increase mortality if you're over-treating or under-treating someone. Now, I have to say that I do get skeptical about maintaining high levels of T4. I have studies that I'm just completing in my lab that will hopefully will be published at some point in the future, in which we show that an excess of T4 can actually reduce thyroid hormone signaling in the brain. So I can make some parts of the brain hypothyroid when I treat an individual with an excess of levothyroxine. So I really don't like that. That's why I like combination therapy, because through the combination therapy, we lower the levels of T4, and at the same time, we elevate the levels of T3.
Perfect, that makes sense. This next question is also along the T4, T3 levels. So the person mentions that you often explain the body will do everything it can to keep T3 in range. So they're wondering, why is it common to find a TSH and a T4 level that are in range and a free and total T3 levels that are below the range in chronically ill patients? So they're referring specifically not to those that are acutely ill in hospitals or starving, but well-nourished people struggling with illnesses like chronic fatigue syndrome. Would you happen to know why this is?
I mean, that's so here's the hypothalamus is what controls the T3 levels in the circulation. And most of the situations, the hypothalamus will use the thyroid to preserve T3 levels in the circulation. And we know, as mentioned in the question, that when you stress the system, when you threaten our homeostasis with a chronic disease, with a life-threatening disease, or when you don't eat enough calories, T3 levels will go down because the hypothalamus will allow T3 to go down. Now, there are individuals that do have lower levels of T3 in the circulation with normal TSH levels. Is a situation that could be called as central hypothyroidism. In other words, the T3 is dropping, but the TSH is not doing anything to defend that T3. And it is a difficult situation because the doctor will have to investigate the possibility of central hypothyroidism. And that is a rare condition, is not frequent. It maybe 1 or 2% of the patients have central hypothyroidism. Is a condition in which we cannot trust the TSH to make a correct diagnosis. There will be imaging studies. There will be a lot of studies. And if the patient has central hypothyroidism, then we have to treat this patient with the appropriate doses of T4, T4 plus T3, without giving a lot of importance to the TSH, because we already know that the TSH doesn't respond.
Perfect. So this is regarding the wait time to reaching a steady state. So we know that for T4 levothyroxine, we usually wait 6 to 8 weeks to see how the state evolves. And so with the combo T4 and T3 therapy, how much time is required before the T3 actually reaches the steady state?
So in theory, the steady state will be reached faster just because the kinetics of T3 are faster than the kinetics of T4. However, every time I make a dose adjustment on T3, I also wait 4 to 6 weeks or 6 to 8 weeks as well, because there's a lot of practical issues. I can't just have patients return next week or within 2 weeks to the clinic. I mean, the patient needs to see how they feel. So I think it's reasonable to assess the patient every, 2 or 3 months.
Okay. The next question is about diet. So ketogenic and low carb diets seem to lead to very low T3. Is this
Sure.
pathological, or is this an adaptive response to the
No,
diet?
it is an adaptive response. Both D1 and D2, these enzymes that convert T4 to T3, they're very sensitive to carbohydrates. They're stimulated by carbohydrates and insulin. So once you cut carbohydrates from your diet, you're going to see a drop in T3 levels just because you're converting less T4 to T3.
Okay. So this question's a little bit longer. It refers to your book. So in your book, you stress the need for accurate diagnosis before starting treatment. The guidelines are clear for overt hypothyroidism above range TSH and below range T4, and subclinical hypothyroidism, which is above range TSH and in range T4. But there seems to be some gray area when TSH raises above 7 or 8 and T4 remains in range. At what level of TSH do you trial medication, and how often is it effective in this type of situation?
So so the question is about subclinical hypothyroidism and when to start treatment. There's not a lot of evidence that treating patients with subclinical hypothyroidism will lead to great improvements. However, this is an area that depends, it's very specific for each patient. I don't think we should generalize here. We should first further investigate, not trust only the TSH. For example, is there a family history of hypothyroidism for this patient? That's number one. Number two, are TPO antibodies, the Hashimoto antibody, are they positive or negative? If you have a TSH of 7 with positive TPO, it's likely that there's something happening there. The third thing, let's repeat the TSH. Let's wait 3 months and see what happens. Is the TSH further up? In many cases, the TSH will return, but I think having a second time point is important. The third thing, or the fourth thing, would be a thyroid ultrasound. A normal thyroid to the ultrasound would make me be hesitant to start treatment. In contrast, thyroid with a patchy pattern, I mean, a texture that's not really normal, will tell me that there's some destruction going on. So this is most likely Hashimoto's that's going to be progressing. So I would be more likely to start treatment for that kind of patient.
Okay, thank you. So another one is, if a patient is heterozygous for both the iodinase 1 SNPs, could that lead to chronically low T3, or will the body compensate somehow, maintaining T3 at optimal ranges regardless?
Okay, that's a great question. So if the thyroid is healthy, the body will compensate. And I say this with confidence because we created a mouse that did not have a single deiodinase in the body. It didn't have D1, didn't have D2. And the T3 levels were normal in this mice. So that means the thyroid, the hypothalamus will detect that there's lacking T3 in the circulation. It will stimulate the thyroid will speed up the production of T3 and will defend the serum levels of T3 even in the complete absence of the deiodinases. So we don't see an effect here. Now, when this patient becomes hypothyroid, if that patient becomes hypothyroid and is now treated with levothyroxine, now that patient only depends on the iodinases to produce T3. So if there's a SNP that will, a SNP meaning a polymorphism in either D1 or D2 that will affect the conversion rate of T4 to T3, that's the situation when you could have a problem. There are some reports. This is a little bit of a controversial area. Some studies show that the iodinase SNPs are important. Other studies did not find a clinical relevance for the SNPs. We have observed that the SNPs, they depend a lot on the genetic background of the patient. And in certain areas, in Europe or Asia or in America, you could have different genetic makeups or background of the patients, and the relevance of the SNP depends on all the other genetic background. So this is an area we need to study more. We don't have enough data to reach meaningful conclusions.
Perfect. So with regards to thyroid cancer patients that are on TSH suppressive doses of T4, would you still recommend to keep the TSH in normal range?
No, I mean, if they have thyroid cancer and they have to be on suppressive therapy, they should be on suppressive therapy. There's usually that will depend on each case. If the patient has metastasis, doesn't have metastasis, what are the level of thyroglobulin? But if the decision has been made that the TSH has to be suppressed, the TSH has to be suppressed.
Perfect, thank you. Okay, so for those treated with combination therapy, you recommend testing free T3 about 3 hours after taking the medication to capture its peak. The person is wondering if you're just making sure it doesn't exceed the reference range, or if you're trying to target the upper part of the range. Please explain what you're looking for.
No, the first point, we want to be safe. We do not want to cause thyrotoxicosis. So remember, that patient is going to be on that regimen for life. So I feel confident that I'm not harming my patients because the T3 levels are within the normal range. So we want to see that the peak of T3 remains inside the normal range. And obviously, you want to ask the patient, did you feel anything? Do you feel palpitation? Do you become jittery 3 hours after you take the tablet? Or do you sweat? I mean, these are all indications that clearly the patient experiencing symptoms of thyrotoxicosis, which will lead me to reduce the dose of T3.
For sure. Okay, so certain drugs like retinoic acid can lead to central hypothyroidism. Are there any effects of, are the effects of the retinoic acid temporary and reversed when the medication is stopped, or does it lead to permanent central hypothyroidism requiring lifelong treatment?
They are reversible.
So the next question is regarding one of the studies you conducted. The person is wondering if the asymptomatic patients who did not improve on the combo therapy over monotherapy have measurements of LDL.
Right. So there are studies that have done this. However, the lipid profile has always been a secondary outcome or just a peripheral outcome of these trials. We don't have trials that actually were powered to look at lipid levels. So we have to do that. I think we were not aware of this happening, and that we were not aware that we should account for the patients taking statin or not. So the next trials, we should actually power appropriately to see significant differences in the lipid profile. We don't have that, what the individual asked.
Okay. So if the TSH is suppressed in combo therapy and the free T4 and free T3 labs are all within range, how would you bring the TSH up to the normal range?
By lowering, so if the T3 is not going outside of the range, if the patient does not have symptoms of experiencing symptoms of thyrotoxicosis, I would lower the dose of levothyroxine.
Okay. And is there a benefit to monitoring free T3 over total T3 if a patient is on T3, or indeed measuring both?
So that's an interesting question. The T3 assay, the total T3 assay, is not a very good assay. What I mean by that is that the precision is not that great. So there's a variability. You can have, if you draw blood now, I could get 85, and if you draw blood 1 hour later, it could be 95. There's about 10%, 15% variability, especially in the lower levels of total T3. Now, the free T3 is even worse than total T3. So the American Thyroid Association issued recently recommendations on what would be the ideal test to utilize, and they recommended we should use total T3. In reality, patients will bring everything, will bring total T3, free T3, and all sorts of reverse T3. And so I try to rely more on total T3, and I am reaching out to individuals involved in laboratory of thyroid function tests to start implementing measurement of T3 through mass spec. Mass spectrometry is the best method, is the gold standard for measuring T3 that is used to measure several steroids in the blood. So we should definitely use mass spec to measure T3 in the circulation.
Okay, perfect. So the next one's a little bit lengthier, so bear with me. It's going back to the deiodinase polymorphism. So the person is asking, how can you investigate whether deiodinase polymorphisms such as RS225014/RS1288530 and certain phenotypes that a patient have are related? So in your book, you mentioned that the results from the study type 2 deiodinase polymorphisms cause ER stress and hypothyroidism in the brain. And your Hungarian colleagues took brain tissues from mice and humans that were homozygous for RS225014.
Mhm.
They were able to observe ER stress and accumulation of misfolded proteins in the Golgi apparatus. So from what the person understands, there's also an increased expression of deiodinase type 2 in brown adipose tissue. So the question is, do you think it would show the same pattern of ER stress / UPR if you were to do a biopsy of BAT in patients with the variant? If so, could that indicate a connection?
Okay, thank you. So we have studied this in the human brains using samples from a brain bank, and we did find ER stress and UPR activation. I assume that we would find the same thing in brown adipose tissue of these humans. I think it would be tough to do a biopsy of brown fat in humans. I don't think that would be, I don't see how that will, I mean, from a study point of view, that will be interesting. We have done that in mice, and yes, indeed, brown fat of mice does have a major ER stress and activation of UPR. So I am satisfied knowing that the brain has ER stress of patients. So meaning that the possible way or mechanism through which the misfolded D2 with the polymorphism is disrupting thyroid hormone signaling is maybe through ER stress. So I am satisfied with that. I am more concerned, as I hinted in the previous question, that the mouse studies are very clean because mice are isogenic, meaning they have identical genome. They're all identical. So there's nothing else that's different. The only difference is the little SNP. Now, when we are talking about humans, you have a much more complex scenario because it's not only the SNP that is different. You know, when you compare different individuals, the whole genome is different. So the environment in which the SNP exists is greatly affected by the rest of the genome. So I think we have to think about this, and future studies should look into how different populations might behave in terms of these SNPs.
So there's a second part to that question. So in the same study, you also observed that the chaperone molecule for PBA reduced symptoms for mice with the genotype variant. If you were to give people with this variant, the 4PBA, or a drug containing that, for example, ammonaps, and the symptoms disappeared, could that indicate that the patient's symptoms can be linked to this genotype?
Yes, I think so. You know, there are two chemical chaperones that could be used. I know TUDCA, tauroursodeoxycholic acid. It's a good chemical chaperone that can be safely used. I wasn't aware that for PBA, the phenylbutyric acid, it can be used. It's already formulated in the drug, but these are studies done in mice. I mean, I have no evidence that this would be either effective or safe to repeat in humans.
Okay, perfect. So I think I have a few questions now from thyroid patients. I'm going to try to kind of lump some of them together. I guess first is with regards to Hashimoto's thyroiditis. So first, they're wondering if this combination therapy is available for those patients.
Yes, combination therapy can be used for any form of hypothyroidism, either Hashimoto's or photothyroidectomy or post-treatment with radioactive iodine. Yes.
Okay. And along those lines, is there any particular reason why there's no antibody testing that is being done to identify Hashimoto's early enough to prevent it from further destroying the thyroid gland?
So that's an interesting question. When we, you know, logically, that would be the way you treat hypothyroidism, right? You stop the destruction of the thyroid gland. However, we don't know how to do that. This is an autoimmune disease. You know, we have not identified ways of slowing down the process. And because the idea through these last 70 or 80 years, hypothyroidism is super simple to treat. Just give levothyroxine. So why do we have to bother understanding autoimmunity or stopping the autoimmune process if we can just treat them with levothyroxine? So there's surprisingly not a lot of research done in terms of understanding the autoimmune aspects of the disease. We don't tackle the disease by stopping the process. We tackle the disease by trying to replace the thyroid hormone production once it is destroyed.
Okay, perfect. So if we have a patient here who had a thyroidectomy, I'm not sure if it's a full or a hemi, a while ago, and is also recently diagnosed with hyperparathyroidism, awaiting an operation. They're concluding that high calcium may have affected the hormone conversion. Do you think this is likely?
I am not aware that elevated calcium levels could affect the conversion of T4 to T3. So therefore, I have nothing to base my response. I would have to say this hasn't been described, but I'm not sure if it has been studied as well. So I would be just careful and say, I don't know any studies that have looked at that.
Okay, perfect. The patient's also trialing liothyronine at a pretty low dose, thinking that it's working. But they're wondering, are there any studies showing how much more liothyronine may be required for poor converters? And the person notes that they're homozygous for DIO1 and heterozygous for DIO2.
So the purpose of treating with combination therapy is to make the patient feel better. So I don't think there's a dose or a predefined level that we are aiming at. We are aiming at the patient feeling better within the limits of the normal range for T3. So I rather have this conversation with the patient, start with a low dose and say, how do you feel? Do you feel any difference? Should we keep it? Should we increase? Instead of looking at the numbers, say, well, I look at the numbers more from a safe point of view because I don't want to trigger thyroid toxicosis. I want to be safe in that regard. And what's going to guide me in the changes are how the patient's feeling within the safe ranges.
Yeah, that totally makes sense. If we take a look at people with emotional and mental health symptoms, including low mood, brain fog, low energy, high anxiety, but that also have normal TSH blood work and a history of a full thyroidectomy, the messaging from professionals usually is that it has nothing to do with the thyroid function, given that the labs are normal.
Correct.
So the question is, what would you recommend in these cases?
Well, I have told that to my patients for decades. Your TSH is normal. There's nothing else I can do. However, we know today that we have luckily evolved from that position. And we know that in that situation, it's worth trying combination therapy. Now, before you try combination therapy, the physician needs to work with the patient in terms of, number one, identifying other possible reasons. Let's say the patient has diabetes. And so the symptoms, the residual symptoms of hypothyroidism can be confused with diabetes symptoms as well. So if that's the case, it's not going to help if we adjust the dose of T4 or T3. What's going to help is if we manage the diabetes situation better. The patient might have vitamin deficiency. The patient might have other autoimmune conditions. So if that's the case, changing from monotherapy to combination therapy is not going to help. We first address everything we can identify that could possibly be wrong. Once we have taken care of everything and the patient still has the residual symptoms, that's when we try combination therapy. And again, reminding, we have to lower the dose of levothyroxine and start with a little bit of T3.
Okay. So this next question, many patients who require higher doses of LT3 to have optimal signs and symptoms have suppressed TSH, but do not have thyrotoxicosis or osteoporosis. Is it really helpful to keep checking TSH when it's known to be suppressed?
Yes, I think it is helpful to know what's going on. So I think that this is a reality. We all see this. Patients that, in order to feel better, they carry a suppressed TSH. That's a very contentious point because we know that a suppressed TSH is associated with increased cardiovascular events and bone fractions. It doesn't mean that the patient is going to have atrial fibrillation or will have a bone fraction. It means that the likelihood has increased. Let's put it this way. If in a city, in a town, the speed limit for cars is 40 miles per hour, when we have a certain number of accidents, if all of a sudden the mayor says, no, the speed limit now is 45, it doesn't mean I'm going to hit my car and something else. It means that at the end of the year, when I look at all the accidents, most likely the number of accidents will increase from a population perspective. It doesn't mean that one individual person is going to have a car crash. So having said that, I think this is when we talk to the patient, monitor the possible adverse reactions, cardiovascular and bone, and we explain to the patient the risks and benefits of carrying forward a suppressed TSH. So do you prefer to have poor quality of life in a normal TSH or have a better quality of life in a suppressed TSH, knowing that having a suppressed TSH has been associated with a slight increase in atrial fibrillation. And this is what shared decision making is called. We have to explain the patient and let the patient make a decision together with us.
Yeah, thank you for that. So there was a question, sorry, about whether or not you had a preference for adding synthetic T3 or if you preferred using desiccated thyroid instead.
Because I think the approach is a customized approach, I think synthetic T3 will give you more latitude, and it will be easier to make small changes in the ratio of T4 to T3. Having said that, it seemed, looking at the numbers, that 1.5 million patients are taking desiccated thyroid extract. I have to say that it's maybe this fine-tuned customization might not be that critical, and but we certainly need more studies. That my personal preference is to have the synthetic, but I have to acknowledge that it's just amazing that there are 1.5 million people taking desiccated thyroid extract just in the US.
Mhm.
Dr. Bianco, do you think we should take another 2 or 3 more questions? And
Of course, I have my lunch is much later than now, so I'm available.
okay, we'll take a few more.
Okay, sounds good. Yes, there were definitely a lot of questions today. Okay, so still trying to kind of group some questions together. One question would be, would you promote the use of increasing thyroid hormones in the winter and reducing it in the summer due to seasonal fluctuations?
Mm, mm, mm. That's interesting. I don't think so. I mean, I think that we don't have clinical trials showing any benefit to that approach. It could be beneficial, but there's no evidence that the patients will feel better or worse, or whatever. That's worth the work, the effort.
Perfect. Another question. So in the UK, there's some areas that have like an upper limit of 10 micrograms of T3 daily, regardless of the patient's needs. And so they're wondering if you have a maximum T3 dose in mind for patients. Neither.
I think that having these rules, I don't think it's necessary to have these rules. I think that in the UK, they could, I'm speculating here, they could have placed these rules in terms of, because they have other issues. They have budgetary issues. They have the price of liothyronine that's expensive. So maybe that's one of the reasons. I know this, although this is not recommended by any guidelines, I know a significant number of patients that only take T3. They don't take any levothyroxine and they feel fine, and they've done it for a number of years. Why they prefer taking liothyronine alone, I have no clue. Maybe they have a genetic condition, but in fact, the reality is they exist. And to put a limit of 10 mics per day, it would do a disservice for this very small number of individuals. So I would not, but maybe listening to the other side, to the doctors, why did they come up with this limit, would be useful as well.
Mm-hmm. So another question is, if a patient had been placed on the medication unnecessarily for subclinical hypothyroidism, they state that it'll ultimately downregulate the endogenous production of the thyroid hormones. So the question is, what would you say is the safest way to wean them off of it?
Just stop it. I don't think that there's need to wean them off. I mean, the thyroid will respond very rapidly and effectively. I mean, it's not like the adrenal glands that when you suppress the adrenal glands with exogenous steroids, you have to slowly wean them off, 5 days and 5 days of you don't have to do that for the thyroid gland.
Okay, perfect. I guess, would you recommend selenium supplementation to aid in the conversion of T4 to T3? Because
No. The selenium deficiency, it is true that the deiodinases are selenoproteins, and the selenium deficiency it exists. However, it has not been shown to impair conversion of T4 to T3. Having said that, there are several studies that showing that selenium supplementation could be helpful in terms of slowing down the progress of Hashimoto's disease. Just because selenium is an antioxidant molecule, it could slow down the autoimmune process, not necessarily the conversion of T4 to T3. We know that the conversion is not going to be effective.
Okay. Maybe for the last question, it's a little bit more of a fun question, but some people are wondering if you're thinking of writing a sequel to your Rethinking Hypothyroidism book.
Everything I knew is already in that book. I have to probably, in 40 years, I will know enough, maybe more, to write another book. Maybe a second edition of the book, but not necessarily a sequel. I think there are a lot of studies that have been published recently on this subject, very interesting studies, and maybe a revision of the book to include the new studies would be really helpful.
Perfect. Laz, what are you thinking for timing?
Thank you, Michelle. Thank you, Dr. Bianco, for a most interesting presentation.
You're welcome.
A little bit different from last year. So we have both of them now, so it's really good.
Yeah.
Complementary. I would like to also thank our webinar team for making this educational event a success. I'd like to mention that if you have some spare time and would like to volunteer to help others with thyroid disease virtually from home, please call us on our helpline at 1-800-267-8822 or email us at info@thyroid.ca. You can also assist us by becoming a member or making a donation by visiting our website at thyroid.ca. As you exit the session, please take a moment to complete our short survey. You'll also have an opportunity to enter your comments. This will help us improve future webinars. Our next webinar will be on mental health and thyroid disease with Dr. Jack Wall on May 26th. We hope that you will join us then. Thanks again, Dr. Bianco. Thank you very much.
It's my pleasure, Les.
Thank you very much, everyone.
Bye-bye. Have a nice Sunday.
Bye now.